Forgive me, first of all, I'm English, so I hope that I don't speak too quickly. I know it's a foreign language to most of you, especially the Americans. I'm told I shouldn't insult my audience straight away, but I managed to do that. So I'm going to be presenting to you on the changes impacting you on ICH E8 R1. This has been in draft format for a long time now. It should be finalized quite soon, but up until now, I think this is what we've got. So I'll tell you a bit about myself first of all, and then we'll get into the presentation. So I've got some 42 years of experience in clinical research, started in the National Health Service, and then I was with Boehringer Ingelheim for some 32 years. And during the last 4 or 5 years with Boehringer, I worked with Transcelerate. And more recently, over the past 5 years, I've had my own consultancy where I've been training multiple companies on ICH E6 and E8 and changes in methodology. So I'll show you some of those companies just to give you an impression. Where I've got non-disclosure agreements still, I've just indicated the company top list, whether in the top 20, top 30, medium size or small. So when I'm talking to you, it's not just about Boehringer Ingelheim, it's about the many different companies I've worked with, and also I'm a frequent presenter at different industry events, and so I gain feedback from those, and so I also talk about what they're doing. So I'm going to describe the ICH E8 changes and explain the impact on clinical trial conduct that these have, and then discuss your opportunities for implementing the changes within your organization. Now, I'll try to remember to indicate that it's just sponsor rather than saying I'm a company, CRO, or anything else, because I know you come from a multitude of different organizations. So first of all, I'm going to talk about the regulatory path. I think it's essential to understand where we've come from and where we're going to and why the regulators want these changes. Then talking a bit more detail about ICH E8 R1, and I've got a lot more text in there than I'll actually present. I'm going to present you with some highlights and then how to address the gaps. I hope to leave sufficient time for questions and answers. I do tend to talk too much, and so I hope to still leave you with a lot of time at the end. But as I said, please ask questions beforehand. And these are the regulatory path. And I'll explain to you how I've got to this regulatory path. So first of all, this is what the regulators think about us. They believe we do testing in quality and not quality by design. That picture on the left is testing in quality. This is actually from a slide set used by the EMA, the European Medicines Authority. Having reviewed something like 1,600 SOPs in the past 5 years, I can confirm that that image that the regulators put up of testing in quality is exactly what we do. We have the same problems going across different companies. We are held together by sticky tape and string, our SOPs, and they're not robust enough to meet a quality by design. Now, I came into this area, as I showed you from my background, I'm a statistician, medical statistician, but I've done virtually every role in clinical research. But I came to the attention of the FDA early in 2011 because of my work on risk-based approach. We've been doing a study within Boehringer, which was a very early one on risk-based monitoring. I was asked to present at this Clinical Trials Transformation Initiative meeting in August 2011, where the regulators were presenting what they wanted. Now, it was a difficult meeting to attend because there was a lot of criticism of industry. And at first, when you're being heavily criticized, you become defensive. But I persisted, and I'm thinking of the problems, and I'm discussing it with the regulatory people that I've met then and over the past few years. I've come to believe they were exactly right. They were concerned about quality of what we do. Now, typically, in any submission we do to a regulatory body, we have a statement which we have to make about GCP, and we typically say we've conducted 30 audits, and therefore from this we conclude that all the studies were run to GCP. And yet, as you probably know, 95% plus of our audits have GCP findings. So how can we make that conclusion that despite all these audits having GCP findings, that everything was run to GCP? And the regulators know that they choose two sites for inspection, and they always find GCP findings.